To introduce Jelene Carvalho. Jelene, who many of you in the room know, has been in the field of fetal cardiac screening and diagnosis for over 30 years. She's head of the fetal cardiac unit, fetal cardiology at the Brompton Hospital. She's also chair of the fetal cardiology interest group at ISUOG, and has also been a past fellow at ISUOG some years ago, and has lectured and been teaching in this field for many, many years. So it's a great pleasure for us to have Jelene to come over. And we have both, not only Jelene, but we also have Bev Goodman-Tai, both from the Brompton, who will be talking to us and giving us a perspective from the pediatric side. And so not only just for this talk, but for all of our talks, to get that important input in terms of pediatric management and outcome of all these anomalies. Jelene, over to you.
Thank you very much, Simon. Good afternoon, everyone. Good morning, good afternoon, good evening for the 700 people there around the world. I am going to have to ask to put the lights down a little bit because I've got lots of clips, and otherwise reproduction might not be as optimal as I would like. So I've been asked to talk about, I put my timer on. I'll go over. Double outlet right ventricle, classification, diagnosis, and management. I have no conflict of interest, no disclosures. Now, the outline of my talk today is going to be first put double outlet in context of the sequential segmental analysis, classifying according to the position of the ventricular septal defect, discussing a little bit about the clinical subtypes and management, and a bit of a word of caution at the end. So if we start with the sequential segmental analysis, and I hope you all are more or less familiar with that, which is an important method to describe heart abnormalities, particularly if they come into the complex group. We know that the heart has three main segments: the atria, the ventricles, and the arterial trunks, and these are connected at the atrioventricular junction and the ventricular-arterial junction. So when you look at the heart from the scanning point of view, the situs will tell us about the morphology of the atrial chambers and the position of one in relation to the other one. The atrioventricular connection tells us about how the ventricular myocardium connects to the atrial myocardium, and the ventricular arterial connection, how the ventricle connects to the arteries. So if we take the sequential segmental analysis that as pediatric cardiologists we try to do in all cases, although we might just jump into saying transposition or tetralogy of Fallot, but for double outlet right ventricle, it's very important that we follow the sequential segmental analysis, and I think it will become clear as the talk goes along. So we should describe the situs, the atrioventricular connection, the ventricular-arterial connection, and the associated abnormalities. So in this segmental analysis, double outlet right ventricle is a type of ventricular-arterial connection. So which means that both great arteries, or more than 50% of both of them, arise from the right ventricle. So they can coexist with any situs, so it could be situs solidus, it could be situs inversus, it could be isomerism. It can coexist with any type of atrioventricular connection, so it could be concordant, discordant, double inlet, or absent connections. So in this talk, because it's quite a lot to cover in 20 minutes, I'm going to concentrate on cases that have a normal situs or situs solidus, that is the atria are in their correct position. Any hearts that have a biventricular atrioventricular connection. So we have each atria connecting to a separate ventricle through their myocardium. So after that brief discussion about sequential segmental analysis, I'm going to have to group the classification according to the ventricular septal defect with the clinical subtypes and management, because one informs the other. So those two topics are going to come separately. So it come together. So what are the types of double outlet right ventricle? We have Double outlet, DOV, with subaortic ventricular septal defect, subpulmonary VSD, non-committed, and doubly committed. So we're going to try and go through each one of them and give you some examples. So if we start with subaortic VSD, it means that the VSD is in close proximity to the aorta. So blood flows preferentially from the left ventricle to the aorta, and this is important in terms of predicting the clinical picture. There is a normal relationship of the aorta and pulmonary arteries, so they have a crossover, as you would see in the normal heart, and pulmonary obstruction is common. So let's start with some examples. Double outlet right ventricle, subaortic VSD, and I'm going to start with a case that doesn't have pulmonary stenosis or very minimal pulmonary stenosis. So this is called a VSD type, which is a clinical classification. I hope this projects well. Are the lights as low as they can go for me? So we start here with the cytosolids. This is the left side of the baby. I hope you can see well from there. So this is a sweep from the abdomen to the upper mediastinum. And I'm playing it back and forth, so you can see the right ventricle, the left ventricle, an overriding vessel. Comes to the three-vessel view. I'll slow it down with my hands, it'll be easier. So here we have the left ventricle, the right ventricle, an overriding vessel, which could be anything, until we see the second vessel, if there is one. So as we move up in the mediastinum, you can see the aorta overriding the VSD, and we only know it's the aorta because as we go further, that's the aortic valve, which is coming predominantly from the right ventricle, more than 50%. And then as we go further, we have the pulmonary. And you can see that three-vessel view is practically normal because there is no obstruction and the vessels are normally related, so they have the crossover. So this is a kind of slowing down that picture. Left ventricle, right ventricle, overriding aorta. Aortic valve is normal. Pulmonary crossing over, normal branches of the pulmonary arteries. And as I said, a normal relationship. So your three-vessel view is normal in terms of orientation when there is an overriding aorta. If we look at the color, we see the aortic flow coming predominant from the left ventricle and the pulmonary. And if you see here, there's an aberrant right subclavian artery as well in this baby. So this is double outlet with a subaortic ventricular septal defect. The flow is going from left ventricle to the aorta and is the closest to the VSD. No obstruction. So this is why it's called subtype of VSD type. The manifestation, there is no obstruction. Postnatal, you can predict this baby is going to go into heart failure from around 2 weeks of age or thereabouts. It's going to be commenced in medical therapy, diuretics, and so forth. And then eventually it's going to go for surgical closure of the ventricular septal defect. So it's pretty straightforward in terms of management. It's just like a VSD, but has a high association with chromosome abnormalities because of the conotruncal malformations, although most of them do not. So let's see now subaortic VSD with pulmonary stenosis. As I said, in this group, pulmonary stenosis is common. So this is called a tetralogy type in terms of the physiology. So here we have a 4-chamber view. And we see it as we scroll up into the upper mediastinum. In this case, the aorta is entirely from the right ventricle. That's the pulmonary also coming from the right ventricle. So there's no overriding as such. Both great arteries are coming entirely from the right ventricle. In this particular case, there's a bit of thickening of the pulmonary valve. The aorta is much bigger than the pulmonary. So in terms of physiology, this is blood coming from the left ventricle through the VSD into the aorta, and we have pulmonary stenosis with a slightly smaller pulmonary artery. If we look at the color flow, you can see why it's subaortic, left ventricle, flow goes through the VSD into the aorta, and that's our pulmonary outflow tract. So this is tetralogy type physiology, but with the anatomy of the outlet right ventricle. So it's much harder in terms of patching this, because the patch is much longer when you close that VSD postnatally, or the surgeon does. And then we have the extreme of that, the subaortic VSD and pulmonary atresia. Against the tetralogy type, in this case here, we have deviation of the axis, which we see in some cases, not all of them. So four-chamber view, here's the VSD coming, the aorta coming from the right ventricle, and you don't see a pulmonary outflow tract here, but you do see branched pulmonary arteries when you come into the three-vessel view coming up. You can see them here, and the three-vessel view is completely different. So this is pulmonary atresia, subaortic VSD, and pulmonary atresia. So here you have the pulmonary artery, the right pulmonary artery going there, and the left here. Your three-vessel view is very messy in a way. So when you put the color, again, subaortic VSD still, we're talking about that, flow from the left ventricle into the aorta, coming from the right ventricle, and you see the branched pulmonary arteries, blue here into the left lung, and the red there into the right lung. And if you look closely, right at the end, there will be some red flow coming here, which is coming from the duct. So if we look at that in more detail, here we have a kind of your three-vessel view, your pulmonary, your aorta much more to the right, and the superior vena cava here. You do have a main pulmonary artery, but doesn't seem to have any connection to the right ventricle, or we're showing another one. There is some connection, but there's no flow. Right pulmonary artery, left pulmonary artery, and there is flow coming here, because that aorta is going to come up in the mediastinal, give the duct downwards, fuse the main pulmonary artery, goes into the right and goes into the left. So that's the way the blood gets into the lungs. So this is still double outlet right ventricle, subaortic VSD, but with pulmonary atresia. If you go in a kind of more parasagittal view here, right ventricle, you can see the overriding aorta, you see the main pulmonary artery, quite a complicated picture. Right ventricle, so there is kind of an attempt to come there. That's why that pulmonary artery is connected to the right ventricle. But if we put color, we see that this is the duct coming back here from the aorta, hits the pulmonary artery, and go into the pulmonary branches. And no forward flow through the right ventricular outflow tract into the pulmonary artery. So on the tetralogy type, so this is still the subaortic VSD, they will have cyanosis, and the degree of cyanosis will be dependent on the degree of pulmonary stenosis. The more significant the stenosis, the more significant is the degree of cyanosis. So the baby can present very stable. If the stenosis is mild, can go home, saturations maybe in the low 90s, to a baby that is stable and can be stable for a long time, to babies that when they're born, they need prostaglandin infusion to keep the arterial duct open, otherwise blood doesn't get into the lungs. So the baby can have one-stage repair, tetralogy, closure of the VSD, and making sure they take all the obstruction between the right ventricle and the pulmonary artery, or they may need to have neonatal surgery, either a shunt between the aorta and the pulmonary artery, or a duct stent, like a mesh through the duct to keep it open, followed by subsequent repair. In all of these cases, they will need reoperation. That's a very brief summary of this type. Now, still within this double outlet with subaortic VSD, there are cases where the VSD can be very restrictive. The ones I showed you, they're very large. So in this case here, you can see there's a lot of disproportion. Coronary sinus dilated. This baby also had a left SVC to coronary sinus. Left ventricle small. And we see the way out from the left ventricle is through a very small ventricular septal defect. The aorta is coming entirely from the right ventricle. I'm not showing the pulmonary artery here. You can see how small this is here. So left ventricle here, small VSD, small aorta, and an associated coarctation. So in cases like this with such a narrow outflow tract, you are in a hypoplastic left heart syndrome. So quite different presentation from the ones I showed before. It's still with the subaortic VSD. So leaving that aside, let's look at subpulmonary VSD. So is this the VSD that's close to the pulmonary artery, or the pulmonary artery that's close to the VSD? So therefore, blood from the left ventricle will go preferentially to the pulmonary artery. So that's quite different from the subaortic. So it's very important to say double outlet ventricle and something else, because the clinical presentation is completely different and the management. So they have a parallel relationship of the great arteries, so similar to transposition, because the left ventricle is pumping into the pulmonary artery. And contrary to the subaortic one, the subpulmonary one has aortic obstruction, and I'll show you some clips why we have this malalignment VSD that causes obstruction to the vessel coming further away from the right ventricle. So this is, as you can guess, it's called a transposition type on a subpulmonary VSD, so it's a completely different presentation. So here we have a 4-chamber view, left side here. Then I'm going to play this very slowly. It's a short clip, so you can see there's a VSD. And while we call it a malalignment, so the other part of the septum is here. So the septum comes here. It should continue with the aorta from the left ventricle, but look at where the upper part of the septum is. So this is a malalignment VSD. And here we have the aorta coming entirely from the right ventricle, further to the right, and this is the pulmonary artery. So subpulmonary VSD, transposition type. And as I said to you, a lot of these cases have coarctation or subaortic obstruction. So if we look at first glance, we might think that those two vessels are the same size, but you can see that that deviation of that outlet septum further towards the subaortic area can cause obstruction, sometimes quite important. In this case, the aorta is marginally smaller than the aortas, but you have to keep in mind that could be still obstruction. Could there be coarctation, for example? So you may not suspect it from this level, but if you go further, left ventricle, in this view, we see how big the pulmonary artery is coming from the left ventricle into the pulmonary, and it goes back into the aorta, which is much smaller over here, entirely from the right ventricle. So it's still a very good size aorta, but that doesn't completely rule out the presence of obstruction, because we haven't looked at the whole aorta. So this on color here, you can see predominantly a ductal arch, which starts posteriorly because it's subpulmonary VSD. So the aorta is, you're just in the beginning of the aorta here from the right ventricle, and this is kind of overriding. And if we go back to our 3-vessel trachea view, you can see here that although the aorta looks quite good initially and in the transverse arch, very distally, see how small that aorta is. So this baby has subpulmonary VSD and coarctation of the aorta. And this is a sagittal view. This is the end bit of the arch, which was very small, and this is the area of coarctation. So it can get more complicated. Straddling valves are quite common in a way, and it's the mitral valve that usually straddles in double outlet right ventricle. So let's see some example of that. So here we have left and right ventricle, aorta and pulmonary arch, so subpulmonary VSD. But look at that mitral valve. It straddles because the subvalvular apparatus of the mitral valve goes both into the right ventricle and the left ventricle. So it's sitting. It looks almost like could be an AVSD, but it isn't. This is just a mitral valve that opens 50% into the right ventricle, 50% into the left ventricle. And if you put color there, you can see that flow from the left atrium going to both ventricles. And then the flow from the left ventricle goes through the VSD into the pulmonary artery. So it is impossible to close that ventricular septal defect because the valve is sitting in the middle. So this, you have to look for that because this would complicate a heart that could go into a biventricular repair. It's impossible to do that because you cannot close the VSD. So transposition type, obviously the baby's going to be with cyanosis and it's going to require an arterial switch and closure of the VSD plus or minus aortic arch surgery, like in the case I showed you, the head coarctation. But you have to bear in mind that they may require univentricular palliation. That is not a biventricular. If you have a significant straddling, in the case I showed you, cannot close the VSD surgically, or they may have such a severe subaortic obstruction with an aorta that's so small that you kind of go through an initial palliation like a type Norwood, and it goes into a univentricular circulation. So you can see already how much diverse the clinical picture is when you say, oh, this baby has top outlet right ventricle. The question is, so what? So non-committed VSD, the VSD is neither close to the aorta nor to the pulmonary arch, so therefore it's a remote VSD, and the blood flows almost directly into the right ventricle. The vessels can be normally related or they can be in parallel. The important thing is that it doesn't go preferentially to either artery, and it's difficult to close that VSD and put the artery back into the left ventricle, and they can have associated abnormalities. So this is an example of such double outlet right ventricle. You can see here is more of an inlet VSD close to the AV valves, and you can see the flow going straight into the right ventricle. So we're not seeing either great artery here, and when we look at the great arteries in a more sagittal view, that's the septum coming here, the pulmonary arch. So in this case, they are normally related. Take it back. It's not normally related. They are not side by side. That's the aorta anteriorly and the pulmonary artery posteriorly. So if we look at the sagittal views, we have the vessels in parallel with no obstruction to the aorta. So parallel relationship, not normally related, as I initially said. So the presentation is going to be variable depending if you have pulmonary stenosis, aortic stenosis, but they all require univentricular palliation. So you can't close that VSD and put either the aorta or the pulmonary artery back into the left ventricle. Then we come to double outlet. Just the doubly committed one. The VSD is close to both great arteries, the aorta and the pulmonary artery. This is not very common. There's no outlet septum, so the VSD flow goes to both arteries simultaneously. That's not very common. It may be difficult to demonstrate. Unfortunately, I don't have very good pictures of that, so I'm going to skip on that. I will show you that it can be even more complex than what you've seen so far. So I'm going to change now to one example of double outlet with abnormal situs and AV connection. It can occur with abnormal situs or AV connection, as I said at the beginning. My example is situs solitus with AV discordance. That is, the ventricles are inverted, and we have double outlet. So let's see an example of that. So the right ventricle is to the left. You can see here just about the offsetting is reversed. The pulmonary veins are coming into the left atrium because the normal situs. The systemic veins come into the right ventricle, into the right atrium, and it goes into the left ventricle. There is atrioventricular discordance. When you go into the vessels, you can see the right ventricle giving rise to the pulmonary and the aorta. The VSD is closer in this case to the aorta, but you can see that the blood flow, despite the aorta being close to the VSD, the flow seems to be streaming more towards the pulmonary artery. So what we see in that picture is blood from the left ventricle, which is on the right side, goes through the VSD, and instead of being preferential to the aorta that's sitting here, on color, it goes preferentially to the pulmonary artery, which is further away. So this is an unusual type of AV discordance with double outlet right ventricle, in which the aorta is to the right. In most of this case, the aorta is to the left. So you see there's always exception. So blood that comes here from the right atrium is desaturated or less oxygenated into the left ventricle, through the VSD, into the pulmonary artery preferentially. So this is working like congenitally corrected transposition. So although this is a very complex case, this baby is expected to be a bit cyanosed at birth, but well and stable. And this is the clip that demonstrates that. Flow through the VSD, and you can see here the branch pulmonary arteries coming up. The flow goes preferentially into the pulmonary artery. So despite all of the complicated factors, this baby is expected to be well shortly after birth, and then we have to deal with the problem afterwards. So very briefly, I think I gave you an outline of how to diagnose double aorta, what it is in the sequential segmental analysis, how to classify, and the caution there, because I think many times people say, oh, this baby has got double aorta at right ventricle. That doesn't mean anything to the cardiologist. You need to say, is it subaortic, subpulmonary, double committed, non-committed? Do we have aortic obstruction? Do we have pulmonary obstruction? What's the situs? What's the AV connection? So really for double aorta at right ventricle, you need to start from the situs, so you know where the atria is. The atrioventricular connection, so you know where the ventricles are. Double aorta is the part of the whole diagnosis. And then you have to say, is it subaortic or subpulmonary? Then you have to go and say, is there pulmonary stenosis or aortic stenosis or coarctation? And is there something else like straddling valves, bilateral SVCs, abnormal pulmonary venous drainage? So next time you make a diagnosis of double aorta at right ventricle, just think that there is much, much more to that. But despite that, babies are fine in utero. Yeah, look at this baby enjoying sucking his big toe there. So all of these cases I showed you, in utero, they're fine. A lot of them can go home after birth, and then we deal with the problem afterwards, like in a subaortic VSD with no pulmonary stenosis. It's just like a VSD. But if you have one which double aorta at right ventricle, subaortic VSD and coarctation, the baby needs to be on prostaglandin. It needs to have a shunt before it goes home or a stent of the duct. If you have some complicated ones, like the last one, with AV discordance and preferential flow to the pulmonary artery, the baby is stable, can go home, and then we can deal and think what type of operation we're going to do. So just think a bit more when you make that simple diagnosis of double aorta at right ventricle, because it's much more complicated than the name says. Thank you very much.
Thanks very much, Jeleni, for a fantastic talk. And if I can ask you maybe just to come up and sit on the panel here. I mean, I think double aorta right ventricle is one that really challenges us all. Jeleni has presented that beautifully. Dario, if I could ask you as well, if you could come back and join us here.